We are here in the base of ASCO Miami, sponsored by Memorial Cancer Institute, to talk about immunotherapy for lung cancer. This is a very important topic because we have a lot of developments in the last year regarding immunotherapy. First of all, we have now the combination of chemotherapy and immunotherapy as a new standard of care. The FDA recently approved the combination of pembrolizumab with chemotherapy for new patients with stage 4 lung cancer. This was based in a randomized phase 2 study. For that reason, not everybody is embracing this new indication yet because a lot of the physicians are waiting for confirmatory phase 3 data. And I agree with that. I think now we have the option to start a new patient on palliative chemotherapy or the combination of chemotherapy with pembrolizumab. And I think it's very hard to argue in favor or against because, as I said before, the data is only based on phase 2 randomized data. We also are very happy because we have other options for the patients. As many of you know, we already have pembrolizumab approved for first line for patients that have more than 50% expression of PD1, and that's another option for new patients with stage 4 lung cancer. And the interesting thing about this is that despite the fact that nivolumab was unable to get the same indication and approval, we have other checkpoint inhibitors like atezolizumab, durvalumab, avelumab that are on his way to get phase 3 randomized data. So hopefully soon we'll have data with all of these drugs to see if they can also get first-line indication as a single agent or first-line indication in combination with chemotherapy. Another important development in the area of immunotherapy is the fact that we're looking for markers, biological markers that can help us to predict response. Everybody knows about PD1 and tumor mutation burden. We know that as higher is the PD1, higher the chance of response. However, we know that this is not a perfect marker. It's very controversial. There is a lot of pros and cons with PD1. So that's why the story of PD1 hasn't finished yet. The fact is that FDA has drugs like atezolizumab and nivolumab approved without PD1 staining because patients still respond even they are PD1 negative. That's why it's not a perfect marker. With tumor mutation burden, we know that higher the tumor mutation burden, higher the chance of response, and now the molecular marker companies, they are providing tumor mutation burden scores in their results. We have very interesting potential new markers. One of them is, for example, the microbiome. There are studies that, if presented in ASCO, very interesting study, retrospective, unfortunately only, that if you give antibiotics before you start the patient immunotherapy, the chance of response is less. This is based on the fact that if the use of antibiotics destroy the microbiome and the normal flora of the intestine, and that probably has to do with immunotherapy. There is more coming about this topic, very exciting new topic. Also, we have postulating new mechanism of resistance. One of them is the mutation STK11. Apparently, we are very close to confirm that we now have resistant mutations to immunotherapy, something very interesting. And STK11 is one of the potential resistant mutations. And the response to immunotherapy in patients that have this mutation is much lower. Another interesting finding is there is a mechanism of resistance for immunotherapy that is being documented more and more, is the beta-catenin pathway. There are 5 mutations in this pathway, and if the patient has one of the mutations, probably is not going to do very well with immunotherapy. That is why these are all very interesting findings that were presented in ASCO, and we're looking forward to the confirmation of all of this. In general, we can say also that if the patient has a genetic aberration like EGFR, ALK, ROS1, they probably don't do well with immunotherapy as a patient that have wild-type genes. That's another confirmatory fact that we saw in ASCO and many other meetings that probably immunotherapy is not the best choice for patients with genetic aberrations. For example, in ASCO, there was a study with exon 14 skipping mutation, and the patients that had this genetic aberration didn't do well with immunotherapy. They have a very low response rate, around 7% only.